You break an arm, right? And the X-ray shows this jagged white line, and the doctor just points at it and says, well, there it is.
Yeah, exactly.
It's contained. I mean, it's a problem with the definitive clear border.
Yeah.
But what happens when your body's own immune system just sort of starts drawing a map of destruction on your skin?
Right, which is...
And far worse, I mean, what if that map starts to actually spread?
See, that is exactly where the comfort of a simple, localized medical diagnosis just completely falls apart.
Yeah.
We naturally want our conditions to, stay exactly where we found them in this neat little geographical box.
Oh, yes.
But autoimmune conditions, they simply do not respect those boundaries.
No, they don't. Well, welcome to the Deep Dive. Today, we're looking at a chronic inflammatory condition called Lichen Sclerosus, often just called LS.
Right.
And we are really tackling the single most persistent, honestly terrifying question people have when they get this diagnosis.
And we hear it all the time.
We do. And that question is, can it spread to other areas?
It is the question that haunts the patient forums, honestly.
I bet.
Because the initial diagnosis is almost always localized to the genital skin, so the vulva in women or the foreskin and glands in men.
Right.
But the fear of the unknown, I mean, the fear of this just creeping across the body over time, it's practically boundless for patients.
It makes total sense.
Yep.
So to get to the absolute biological truth of this, I've been going through a stack of sources for us today.
Okay.
I'm talking the official clinical guidelines from the British Association of Dermatologists, alongside these massive medical reviews from UpToDate, plus patient data from various NHS trusts.
The heavy hitters, yeah.
Exactly.
Yeah.
And the picture they paint of how this condition behaves over a lifetime is, well, it's incredibly complex.
It really is.
Okay, let's unpack this. Because before we even try to map out where this condition can go on the body, we have to address the most urgent panic that flashes through someone's mind when they hear the word spread.
Oh, absolutely.
And that is, can I give this to someone else?
Right. And it's a totally rational fear to have.
Okay.
I mean, if a condition primarily presents on the genitals, your immediate assumption is going to be that it acts like a sexually transmitted infection.
Exactly.
But the medical consensus across, every single piece of literature we reviewed is absolute on this.
Good.
Lichen sclerosus is not an infection.
Okay.
It's not caused by a bacteria. It's not a virus. It's not a fungus. So therefore, it is entirely non-contagious.
Okay, so just to be crystal clear for you listening, you cannot pass it to a partner.
Nope.
You cannot catch it from sharing a towel or, I don't know, a swimming pool or a toilet seat.
Never. I mean, and crucially, it has absolutely nothing to do with personal hygiene either.
So it's less like a viral army invading your city and more like your own building's internal fire sprinklers just going off when there isn't actually a fire.
Yes.
Like the system meant to protect you is just misfiring and ultimately causing water damage to the structure itself.
I love that. That is a brilliant way to conceptualize it. It is an autoimmune-mediated response. Your immune system is effectively misidentifying your own healthy skin cells as a threat.
Wow.
Yeah, so it triggers this inflammatory cascade, your fire sprinklers, which leads to the scarring and the tissue changes.
Right.
And because it's this internal miswiring, it's biologically impossible for it to infect another person.
Okay, well, that is a massive relief. We've closed the border, right? It cannot jump to another person.
Exactly.
But if this is a systemic issue, if the internal security system is what's misfiring, can that internal system start attacking the architecture in completely different neighborhoods of my own body?
Well, it can, and this brings us to the actual medical reality of the spread.
Okay.
While it doesn't jump between people, it definitely can appear in other areas of the patient's own skin.
Right.
In dermatology, this is called extragenital lichen sclerosus, and extragenital simply means, outside the genital area.
Right. And I was actually looking at the numbers in the UpToDate review, and I was genuinely surprised by this, because this isn't some, 1 in a million medical mystery. Extragenital manifestations occur in about 15% to 20% of patients who have LS.
Yeah, that's right.
That is 1 in 5 people who will see this condition actually appear on other parts of their skin.
It is, yeah, it's quite common. But what's fascinating here is the absolute unbreakable boundary the condition maintains regarding depth.
What do you mean by depth?
Well, it can spread geographically, right, across the surface of the skin, but it never, ever spreads internally.
Okay, I actually want to push back on that a little bit, because if the immune system is the culprit here, and the immune system obviously operates in the blood and the organs,
Right.
why wouldn't it spread inward? What's stopping it?
It's because of the very specific type of tissue that it targets.
Okay.
Lichen sclerosus is strictly confined to the epidermis, so that's the outer layer of the skin, and certain specific mucosal surfaces on the outside of the body.
Ah, I see.
So it just does not affect internal organs. It's not going to move into your bloodstream or your digestive tract.
That's reassuring.
And incredibly importantly for female patients, it never extends inside the vagina.
Wow, really?
Yeah, the internal vaginal mucosa is structurally a totally different type of tissue.
Okay.
So the immune cells that are driving this specific condition literally do not possess the biological keys to attack that internal lining.
That is a huge distinction for anyone listening who might be dealing with this. I mean, if you are experiencing internal pain, the medical literature is telling us that is not the lichen sclerosus spreading inward.
Exactly.
That might be a secondary issue, like maybe pelvic floor tension or something, but the LS itself absolutely respects that internal tissue boundary.
Spot on. It operates entirely on a horizontal plane across the map of your skin, never a vertical internal one.
Okay, well, let's unpack this horizontal map then.
Yeah.
Because if 1 in 5 people get this on other parts of their body, where exactly are the hot spots?
Right.
If I have this, where am I checking?
So the clinical data highlights very specific areas. The most common extragenital sites are the upper back, the shoulders, the neck.
The neck too.
Yeah, the neck, the bends of the wrists, the thighs, and the inframammary areas.
Which is the skin underneath the breast.
Exactly, yes. Under the breasts. And in extremely rare cases, we're talking very rare, it can even show up in the oral cavity, like the lips or gums.
Okay, but what does it look like in these spots? Because on the genitals, the sources describe this intense itching, tearing, and this distinct white figure of 8 pattern.
Mm-hmm.
If I'm checking my wrists or my shoulders, am I looking for that same intense, destructive pattern?
It looks similar, but the symptoms are usually much, much quieter.
Oh, interesting.
Yeah, extragenital LS rarely has that intense tearing itch. It often just starts as small, ivory-colored, slightly raised spots.
Okay.
And over time, as the inflammation damages the structural proteins in the skin, the epidermis begins to atrophy, which means it thins out.
Yeah, the NHS leaflets actually have a very visceral visual description for this.
What do they say?
They say these small spots merge together, and eventually the skin looks like white wrinkled tissue paper.
That wrinkled tissue paper visual perfectly describes epidermal atrophy.
It's very vivid.
It is. But there is a vital caveat in the literature regarding skin tone that we have to mention.
Oh, absolutely, yes.
Because that ivory or porcelain white description, that's standard in older dermatology textbooks, which historically focused heavily on lighter skin.
Right, of course.
On darker skin tones, the condition doesn't necessarily look stark white.
So what are you looking for, then?
Well, the extragenital patches might show up as hyperpigmented, which means they are darker than the surrounding skin, or hypopigmented, which is lighter.
Okay, so it varies.
Yeah, so if you have a darker complexion, you are really looking for a patch of skin that has changed pigment and developed that slightly crinkled, thinned texture.
Now, here's where it gets really interesting. As I was going through the up-to-date review, trying to sort of map out these hot spots, there was a detail that honestly sounds like something out of a science fiction novel.
Oh, the lines!
Yes. The review just casually mentions that sometimes the spread of this condition across the back or the torso follows something called the lines of Blaschko.
It's wild, isn't it?
I mean, I have never heard of an invisible line on the skin. Are we talking about a hidden network of tiny blood vessels or some kind of nerve pathway? What is this?
Neither, actually. They aren't blood vessels, they aren't nerves, and they don't follow the muscular system at all.
Okay.
The lines of Blaschko are essentially a cellular fossil record of your own embryonic development.
Wait, a fossil record? How does that even work?
Okay, so when you were a tiny embryo, a single cluster of cells began to divide and migrate outward to form your skin.
Right.
As those embryonic cells multiplied, they moved in very specific swirling patterns across your developing body.
Just naturally.
Exactly. They formed V-shapes on the back, S-shapes on the chest, wavy lines on the head. And normally, you never ever know they are there.
Because your skin just looks normal.
Right. But certain skin conditions, when they trigger, will preferentially follow these exact historical pathways. And lichen sclerosus is one of them.
But why would my immune system today care at all about a path my cells took decades ago, before I was even born?
It comes down to a concept called genetic mosaicism.
No.
As those original embryonic cells divided, some lines of cells developed microscopic, totally benign genetic variations.
So we aren't perfectly uniform.
Exactly. Your skin isn't one perfectly uniform sheet. It's a mosaic of these ancient cellular families.
Wow.
So when the immune system becomes confused in lichen sclerosus, it sometimes decides that one specific lineage of cells, one specific branch of that embryonic family tree, is the enemy.
That is just mind-blowing.
I know. So the immune attack literally traces the invisible, swirling history of how your body was formed in the womb.
The map of the spread isn't random at all. The immune system is reading a blueprint that was drawn before you were even born.
Very much.
But, that actually brings us to a really crucial realization about the other hot spots we talked about. Because if it's not following an embryonic line, why does it so reliably show up on the wrists or under the breasts or on the shoulders? Like, why those spots?
It is absolutely not a coincidence. And this is perhaps the most actionable piece of information in all the literature we reviewed.
Okay.
The mechanism driving this specific geographic spread is called the Koebner phenomenon.
The Koebner phenomenon. Okay, so if friction is the trigger that turns these invisible blueprints into visible scars, how does this phenomenon actually work?
Well, the Koebner response occurs when a person with a pre-existing skin condition develops new lesions on skin that was previously totally healthy, purely as a result of physical trauma or friction to that spot.
Wait, let me make sure I'm understanding the mechanics here.
Sure.
If I have lichen sclerosus on the primary genital site, but the skin on my shoulder is completely clear, if my heavy backpack strap rubs against my shoulder every single day, that physical friction could literally spawn a brand new patch of LS right there.
Yes, it absolutely could.
It's like a software glitch.
A software glitch.
Yeah, like if I hit the keyboard too hard in one spot, a weird error pop-up appears on the screen, even though the core hardware issue is somewhere else entirely.
That is a great analogy.
Yeah.
Exactly. And the biological mechanism behind your software glitch is basically a misdirected healing response.
Oh, so.
When your backpack strap rubs your shoulder, it causes microscopic damage to the skin cells. In a person without LS, the body sends macrophages and repair cells to just, quietly fix the slight abrasion.
Business as usual.
Right. But in a person with LS, the immune system is primed for an inflammatory overreaction.
Oh, I see.
It sees the micro damage from the friction, rushes to the site, gets its signals entirely crossed, and instead of just healing the scrape, it unleashes the autoimmune attack that creates a new lichen sclerosus plaque.
That completely changes how a patient should interact with their environment. I mean, the sources list a whole range of triggers.
Oh yeah, it's a long list.
It's not just backpack straps. It's tight waistbands that dig in, the underwire of a bra, just tight clothing in general.
Yeah.
And for genital spread, they specifically highlight the friction from incontinence pads or daily panty liners.
Yes. The constant low-level friction, especially combined with trapped moisture from those pads, is a massive trigger for the Koebner phenomenon.
That makes sense?
But the trauma doesn't even have to be ongoing friction.
Really?
Yeah. The medical reviews note that a single historical instance of skin damage can invite LS to settle in that spot years later.
Years later?
Yeah. Things like old surgical scars, injection sites, areas of previous radiation therapy, and even the healed scars from a bout of shingles can suddenly develop lichen sclerosus.
Wow.
The immune system has a very long memory for where the skin's structural integrity was previously compromised.
This is why understanding the how and why of your own body is so incredibly empowering.
It really is.
Because if you know that physical friction is the literal invitation for this condition to move to a new neighborhood, you are no longer just a passive observer waiting to see where it pops up. By simply identifying areas of friction in your daily life, like switching to seamless underwear, ditching the tight belts, maybe using barrier creams to stop chafing, you might actively prevent the condition from migrating to new territories.
It shifts the entire patient dynamic from anxiety to active management. You can't control the underlying autoimmune tendency, but you absolutely have a say in controlling the environmental triggers that invite it to the surface.
Okay, so we know how it spreads through these microtraumas, and we know why it picks the spots it does. But what happens when the wrinkled tissue paper is already there? Like, if I find a patch on my back, what are the actual medical interventions to stop it?
So the first thing to understand is that the strategy for extragenital LS is often fundamentally different from treating genital LS.
How so?
Well, genital LS is aggressive. It causes severe structural changes and fusion of the tissue and almost always requires immediate treatment.
Right.
Extragenital LS, on the other hand, is frequently completely asymptomatic.
Right, so a patch on your back might just be sitting there quietly.
Exactly. And because it's asymptomatic and carries practically zero risk of turning into skin cancer, unlike genital LS, which does carry a small malignancy risk, dermatologists will often suggest simply deferring treatment entirely.
Just leave it alone.
Yeah, if it's not bothering you, you don't necessarily have to declare war on it.
But if it is one of the rare patches that does itch or, if it's spreading aggressively, the doctors will step in.
I will, yes.
And when I looked at the clinical guidelines for how they step in, I was honestly incredibly confused.
Why is that?
Because the absolute gold standard first-line treatment for lichen sclerosus is a super potent topical steroid ointment, usually clobetasol propionate.
That's correct, yeah.
But if you go to the pharmacy, get this tiny tube of incredibly strong ointment and pull out the manufacturer's warning leaflet. It literally says printed in bold, do not use on genital skin.
Ah, the warning label.
I mean, I would panic and throw it in the trash. Why is the British Association of Dermatologists explicitly telling patients in their official leaflets to actively ignore the pharmaceutical warning label?
It is the ultimate medical paradox, really, and it comes down to understanding how the steroid interacts with healthy skin versus diseased skin.
Okay, explain that.
In a person with healthy skin, applying a super potent steroid like clobetasol for a long period will cause the skin to thin out and atrophy.
Right, which sounds bad.
It is bad. That's why the warning is there. You do not want to thin out healthy, delicate genital tissue.
But the skin we are talking about isn't healthy.
Precisely. Lichen sclerosus is actively thickening, scarring, and hardening the deeper layers of the skin through profound destructive inflammation. The disease is trying to turn the pliable skin into rigid scar tissue. So the super potent steroid is the only chemical hammer heavy enough to crash through that inflammation and halt the scarring process.
So it's basically a balancing act.
Exactly. The steroid's side effect of skin thinning actively counteracts the disease's mechanism of skin hardening.
Wow.
So in the context of LS, the steroid isn't a danger. It is the exact biological rescue mechanism required to save the anatomical structure.
That makes complete sense. The medicine is matching the specific mechanics of the disease. But what if the spread is massive? Say the Kubner phenomenon has triggered patches all over someone's shoulders and back. Applying a tiny tube of super potent steroid over 20% of your body just isn't practical, is it?
No, it's not. And doing that significantly increases the risk of the steroid absorbing systemically into the bloodstream, which we want to avoid.
Right.
So for widespread extragenital disease, dermatologists look to alternative therapies. One of the primary alternatives mentioned in the up-to-date clinical review is UVA1 phototherapy.
Phototherapy. How does shining ultraviolet light on the skin fix an autoimmune malfunction?
It is actually a brilliant mechanism.
Really?
Yeah. We know UV light damages cells. That's why we wear sunscreen, right?
Right.
But in a highly controlled medical setting, specific wavelengths of UVA1 light can penetrate deep into the dermis and specifically target the overactive T cells that are causing the inflammation.
Okay.
The light induces apoptosis, which is programmed cell death in those specific immune cells.
So it just kills the bad cells.
Effectively, yes. It clears out the malfunctioning local security system without needing to suppress the immune system of the entire body.
That's amazing. Now, speaking of localized treatments, I noticed a stark difference in how alternative creams work depending on where you put them.
Ah, yes.
The sources talk about topical calcineurin inhibitors, things like tacrolimus ointment. These are immunosuppressants that aren't steroids.
Right.
The clinical data shows that tacrolimus works beautifully for genital lichen sclerosus, but is largely useless for extragenital patches on the back of the arms.
It is.
Why would a drug work on one part of the skin but completely fail a few feet away?
It comes down to the microenvironment of the skin itself. As we mentioned, the skin is not one uniform sheet.
Great.
The very top layer of your skin is called the stratum corneum. It's a layer of dead, toughened cells. On your shoulders and back, the stratum corneum is quite thick to protect you from the elements. But on the genital mucosa, it is incredibly thin or entirely absent.
And tacrolimus is a physical molecule trying to get past that barrier.
Exactly. Tacrolimus is a very large molecule. When you put it on the back, it physically cannot penetrate the thick stratum corneum to reach the inflamed immune cells underneath.
It's just stuck on the surface.
Right, it just sits on top. But when you apply it to the delicate genital mucosa, there is no thick barrier. The large molecule slips right through and calms the immune response perfectly.
That's wild.
Yeah, the exact same drug acts completely differently depending on the geographic architecture of the skin.
We have covered an immense amount of the map today. Let's synthesize this for you listening. First, the most vital takeaway. Lichen sclerosus definitely 100% does not spread to other people.
Never.
Second, it respects the internal boundaries of your body. It will not spread to your internal organs or inside the vaginal canal. It can, however, migrate geographically across the surface of the skin in about 15 to 20% of cases.
And we learned that this spread sometimes traces our oldest embryological pathways and is heavily driven by the Kogner phenomenon,
Right.
where physical friction or microtrauma acts as this open invitation for the confused immune system to create a new scar.
But, you can manage that friction and utilize powerful treatments like potent steroids, ignoring that scary box warning under your doctor's supervision to halt the spread.
Absolutely.
But looking at all of this, looking at how the immune system behaves, there is one final piece of this puzzle that changes how we view the entire condition.
Yes. If we connect this to the bigger picture, throughout all the literature, from the NHS to up-to-date, the text repeatedly mentioned that lichen sclerosus is highly associated with systemic autoimmune conditions.
Systemic conditions.
Yeah, things like thyroid disease, pernicious anemia, and diabetes.
And this is what we hinted at in the very beginning. We spent this whole time looking at the skin as a map of the disease. But if a tight backpack strap can trigger a localized immune response on your shoulder, and that immune response is statistically linked to your thyroid gland malfunctioning,
Well,
maybe we aren't just looking at a skin condition at all.
it raises a profound biological question. Are these white, wrinkled patches on the skin simply the visible surface markers, the dashboard warning lights, if you will, of a much deeper systemic shift in the body's entire immune network?
A shift that modern medicine just hasn't fully decoded yet.
Exactly.
It completely changes the way you look at the map. You aren't just managing a localized anomaly, you are looking at the visible evidence of a dynamic, deeply interconnected system.
It's a reminder that our bodies don't exist in neat little geographical boxes.
They really don't. Keep questioning your maps, keep exploring those boundaries, and thank you for joining us on this deep dive.